Good evening, friends, and a warm welcome to Season 2, Episode 2 of 4D, that is Detailed Discussion and Dialogue in Indian Diabetes. Now, the number 2 is very important because it represents partnership, fellowship, friendship. It represents unity and strength as well. So, therefore, in this second episode of our second season, let's welcome someone who is known for his strength, his friendship, and fellowship. A warm welcome to Dr. Banshi Sabu from Ahmedabad, India. Namaskar, Dr. Now,
Namaskar.
introducing you would take more time than we actually have for the entire episode. So, allow me to summarize in two sentences. There are many people who work for themselves. There are many people who work for their patients. But Dr. Banshi Sabu has worked tirelessly and continues to do so for Indian diabetes. Single handedly, he has been able to take so many Indian doctors, senior, junior, experienced, not so experienced, to the global stage. And he has been able to showcase Indian diabetology at an international level. Thank you, sir, for all the hard work that you've been doing for Indian diabetes care.
Thank you, Sanjay.
Now, when we said number 2 and we said that it's a sign of partnership, this can go in negative as well. And one example is when you have diabetes and cardiovascular disease together. Or perhaps you have diabetes and obesity, or obesity and cardiovascular disease together. When any of these two come together, they can create havoc. So, to learn about how to manage these diseases, overweight or obesity, and CV risk in people with diabetes, we'll request Dr. Banshi to take charge. And this is fitting because apart from diabetes care, Dr. Banshi has also been spearheading as president the activities of the All India Association for Research in Obesity. So, warm welcome, sir, and please carry on with your presentation.
First of all, thanks Dr. Sanjay Kalra for kind words of introduction. Thank you IJCP for giving me this wonderful opportunity. What I am going to talk today the body weight, which is a very important risk factor for diabetes and cardiovascular disease. As we know that obesity in our country is increasing day by day. We have a complex condition which increase subcutaneous and visceral adiposity. The associated with adipose dysfunction and insulin resistance, which increase the risk of diabetes, but not only for diabetes, also for cardiovascular disease. In urban India, out of four, three people are overweight. So, two-thirds of our diabetic patients are now overweight. I mean, the persons who are living a normal person. This is what the prevalence of abdominal obesity is found to be 40% in women and 12% in men. Studies had shown that 5 to 6 out of 10 women between the age of 30 to 49 are abdominally obese. The association of abdominal obesity in women is stronger with older age group, urban residents, wealthier section, and in non-vegetarian. So these are the different data which is being published. I have put some of the references here also, and this is what the obesity in our country. Indians are known to have highest cardiovascular disease. We are having highest number of people with cardio-coronary artery disease. The prevalence of CAD in Indians is roughly 21.4% for diabetics and 11% for non-diabetics. The prevalence of coronary artery disease in rural part of the country is nearly half than that of urban population. In India, around 77 million people above the age of 18 are suffering from type 2 diabetes. Nearly 25 million are pre-diabetics, and adults with diabetes have a 2 to 3-fold increased risk of heart attack and stroke. This is linking obesity and diabetes and cardiovascular disease very nicely in a ADA. It was published in Diabetes Care in 2023, which is talking that how relationship between obesity, diabetes, and a cardiovascular in a phenotype, a UK bank biobank study, which was a cohort which was published. And this link is talking that how obesity related insulin resistance, a person who may not become even diabetic, but as he becomes more and more obese, there is a hyperinsulinemia. This hyperinsulinemia, as well as these adipocytes, they gives more of free fatty acid and more of adipokines. And these are responsible for impaired oxidative capacity, which is a mitochondrial dysfunction. This inflammation and this lipotoxicity both are responsible for not only insulin resistance but also it defects in a translation pathway. If you see, this impaired oxidative capacity is not only by free fatty acid, but other aggravating factors are the excessive lipid intake, the inactivity, the immobilization, the aging, and chronic disease all are responsible for this increasing oxidative stress. This insulin resistance, once, as I told you, hyperinsulinemia, at one point of time, the beta cells are no more able to give so much amount of the insulin and they develop diabetes. At the same time, there is an increasing resistance at the muscles level as the liver level also, and that is responsible for development of type 2 diabetes. First, it starts with pre-diabetes, that's only post-meal hyperglycemia, and slowly fasting hyperglycemia starts. The insulin resistance, which is a hyperinsulinemia, is also responsible for increased MAP kinase activation, which is responsible for accelerated atherosclerosis. Some of the people, even they are just obese and hyperinsulinemic, they have not developed diabetes or even pre-diabetes, still they are at the high risk of developing atherosclerotic cardiovascular disease, and that is the link between obesity and CVD. How we can prevent? Now, prevention of obesity is a primary way by preventing diabetes as well as CVD. Whatever we have to do for type 2 diabetes and CVD, same thing will prevent the obesity. So, limiting unhealthy food, increasing physical activity, limiting television time, improving sleep, and reducing stress. For type 2 diabetes, it is a lifestyle changes, reach and keep a healthy body weight, stay physically active, eat a healthy diet and avoid sugar and saturated fat, and avoid tobacco smoking. And these all are also important for prevention of CVD. So, a healthy diet, increasing physical activity, stop smoking, take care of sugar, blood pressure, and lipids. That is what we say ABC, A1C, blood pressure, and cholesterol. Therapeutic strategy, what we have to do. The weight management, there are few medications which were used previously like phentermine, but now no more use. The long-term use with the early state, but now we have the drugs like GLP-1 and a lot, so we don't talk about the bupropion or phentermine and topiramate combination. But what we want to use is that liraglutide, semaglutide, these are the molecules which we can use. There is a anti-hyperglycemic agents like newer medication like DPP-4, SGLT2, and GLP-1. They are also helpful for decreasing obesity also. The hospitalization for heart failure, the biggest benefit of using SGLT2 in patients with diabetes as well as patients with obesity, as they are at the high risk of developing heart failure, and the hospitalization for heart failure is significantly reduced by using the patients on SGLT2 inhibitor. There are evidence-based studies which talk about HbA1c in fasting plasma glucose, which improved from baseline from DAPA. This is a 24 week study with more patients achieving not only therapeutic glycemic response, but there is a decrease in blood pressure, systolic blood pressure, as well as in diastolic blood pressure too, and that we all know. If I combine both the molecules, they both have different mechanism of action, and that's the reason they are additive. There is an additive benefit of not only for reduction of glucose, additive benefit for the weight reduction also, additive benefit for the blood pressure and other cardiovascular risk factor. So the advantage of combination, it improves insulin resistance and functioning of beta cell. It is safe, rapid and sustained glycemic control. It adds in body weight, blood pressure reduction, more patient compliant. It reduces pill burden. That's the biggest advantage. You are putting two very interesting molecule, important molecule, and that reduces the pill burden, and at the same time it is cost effective also. So these are the benefit of putting these two combination, and they both have different mechanism of action, like they increase the glycosuria and they decrease the weight as well as the blood pressure decrease. Otherwise, here DPP-4, which it inhibits GLP-1 and GIP, it distributes insulin secretion from beta cells. So that's an advantage, and it inhibits glucagon secretion, which is also important reason for hyperglycemia. It's weight neutral and low risk of hypoglycemia. So this combination, which is available across the country, this combination which is very very cost effective, because now it is generic, and the companies which in India they are making, in compared to the multinationals when we were getting from outside, it's very very cost effective, and it is reducing the pill burden for our patients, so they become more compliant for this. Thank you very much.
Thank you, sir, for that wonderful talk, that enlightening talk. And the best part is, such a heavyweight subject, you've managed to finish in such a crisp manner. There are many questions from the audience for you. One question is, uh, when we want to manage diabetes and obesity together, what is the role of dapagliflozin sitagliptin fixed dose combination?
Sanjay, very rightly you are saying and asking the question also, that's very important. When we are managing diabetes now, we are just not managing only for glucose control. Rather, it is for complication preventive approach. And one of the very important approaches other than complication prevention, which is like CVD and cardiorenal, it is the weight management for a person with diabetes. So anytime a person to whom we are treating diabetes, we have to say that we have to see that weight should not increase, and rather it should help that whatever the medication which we are using, it should help us for reduction of the weight. Now, weight management in diabetic patients, because many of our patients are having the BMI of more than 25, but many of them, even they are lesser than that, still they are thin fat Indians. So, they may look that their body mass index may be 23 or 24, but still they are centrally obese or fat percentage. Now, here this combination of DAPA and CETA is really very good for them, because dapagliflozin averagely weight reduction is around 5% of the body weight, maybe 3 to 4 kg weight reduction is there with most of the patients. And sitagliptin being a weight neutral drug, it will not allow further to increase. And some of the data had shown that with combination with sitagliptin along with metformin or even alone, had shown some weight reduction also. So this combination is really very, very good as far as weight management is concerned, because most of our patients, they need actually weight reduction by 5%. And you know that 5% weight reduction improves the metabolic profile like anything. It is not only for the sugar control, but other metabolic parameters are also significantly improved, and they are very, cardiovascular risk factor also. So significant improvement in cardiovascular risk factor also.
Thank you so much, Dr. Banchi. Another question is, uh, would this recommendation, this concept that you have given us, would it be relevant for the entire country, or are there regional variations? Do you see more obesity or more central obesity in some states, or is DAPA sitagliptin a good combination for everyone across the country?
So national data shows that there is a more obesity in north part of India. So I mean, if you compare with Punjab with the Assamese population or the population with South India, Keralites, you will find that yes, there is a definitely more weight or more obese in northern part of India. But still, this combination, as I said you, that we are some of the time we see the person is lean, his BMI may be 24 only, but still, central obesity is very prevalent in India. And across the country, those who are developing type 2 diabetes, most of the time you will find them that they are centrally obese. So it will work for every patient if it is typical type 2 diabetic patients. The only condition which you can say like SID, severely insulin deficient, who are presented with a significant weight loss, all symptom of insulin deficiency, may not be LADA, may not be autoantibody positive. So that variety of patient also we have. So a doctor who is treating, clinician who treats, he knows that these are significant insulin deficient diabetes or a secondary diabetes, post pancreatitis. They may not be the right choice. Otherwise, most of the patients with this CETA and dapagliflozin combination will work very well.
Sir, we have heard of ominous octet by D. Fronzo, and we have also heard of Sabu's 3E model. The 3E model, postulated by Sabu et al., says that E is for endocrine and metabolic, that is everything that Dr. Di Fronzo had discussed. E is for environment and environmental factors. Is the drug available in the neighborhood pharmacy? For example, is there a drugs supply chain which is maintained throughout the 12 months? Can the drug reach a particular patient wherever he or she is in the country? So that is environment. And E is also for economy. Economics is an important factor when it comes to choosing drugs. So keeping these in mind, sir, the Sabu model 3E, that is E for endocrine and metabolic, E for environment, E for economy. How do you place the modern fixed dose combinations that are available in India,
So,
especially speaking about DAPA and CETA?
so if I say the CETA and DAPA gliflozin combination, the first E, which is a metabolic ominous octet, and then you have written very nicely article about the dirty dozen. This all most of the pathophysiological defects are taken care if I combine with sitagliptin and dapagliflozin, except like with the insulin resistance, which is there more with the muscles and the liver. But still, by improving that, also gets improved by putting the patient on SGLT2 inhibitor. So, most of your pathophysiological defects in a metabolic condition and diabetic patients are taken care. Now, the second point, which you are saying very rightly, that accessibility of the medicine should be available around the year, 12 months, and patient can have it. So this is the medicine which is in the combination which is available now in India by most of the Indian pharmaceutical company in a generic form, is available across the country. When you go to the rural most area, like I was just before 3 days at my village, which is Kochaman near Ajmer, a very small town. And I have written some of the patients the medication, this combination, and it was available there also. So that's what the availability of this molecule, which is available. And third, which is very, very important, is more than 50% of our patients are actually not affording. And that affordability, that economy part of the medicine combination is now very well available across the country, because this molecule, when it had come with a cardiovascular outcome trial and data, it was very costly, and we know the benefits of using these molecules. But after 10 years, 12 years, this molecule had become off patent. We are thankful to the Indian industry that they could bring out this molecule at a very, very, very cost effective. I mean, 10 to 15 rupees is the average cost of this molecule. And in combination, the person's fixed dose combination will increase the compliance of the patient, because they have to take only one tablet. So it is economical, it increases the compliance, it is available across the country, and it takes care of all metabolic defects which person can have with a hyperglycemia or diabetes. So I think one of the best combination now we have, and with the cardiovascular outcome trial data also, it shows that it is not only safe, but it is helping our patients for improvement in cardiovascular disease. Like it helps in hospitalization for heart failure decreases. It also helps in the patients for a chronic renal disease. This further progression of CKD is also progression is halted by using the SGLT2 inhibitor. So that also, and with the sitagliptin, we have a CV outcome data also for the neutral data also.
Thank you, sir, for having answered all these questions so patiently. We have a few more questions. If you allow, I can take them. And one question that we have from the audience is, sir, you spoke about the KG-A1C paradox. Does the KG-A1C paradox occur with all oral drugs or only with some? Well, the answer is that with the older sulfonylureas, the old-fashioned sulfonylureas or the traditional ones like glibenclamide, this KG-A1C paradox was seen quite easily. Also with pioglitazone. Pioglitazone increases weight but reduces HbA1c. Though of course the weight increase is it is not visceral fat, it is peripheral fat that is increased in with pioglitazone, and the adipose tissue topography, the type of adipose tissue is healthier, but still there is a KG-A1C paradox. How do we overcome it? The way Dr. Banchi Sabu has said, if you use a combination of drugs which include an SGLT2 inhibitor like dapagliflozin, then you can break the KG-A1C paradox. Another question is, could you please list the drug classes that reduce body weight in diabetes? So here we would have two drug classes right on top. On top, first of all, we have the GLP-1 receptor agonists. You can choose an oral drug like semaglutide, an injectable drug once daily like liraglutide, or once weekly like dulaglutide. These are the drugs that are available for use in diabetes. They are all GLP-1 receptor agonists. They will help reduce weight and also reduce glucose. The disadvantage is that they are expensive, and some of them, like liraglutide and dulaglutide, are injectable. The second class of drugs is the SGLT2 inhibitors, like dapagliflozin, which we've mentioned. These drugs reduce glucose and also reduce body weight. The rough weight loss is something like 3 to 4%, so it won't cross 5%, but there is a lot of inter-individual variability. So when you try it, then you see what the results are. In general, the body weight loss is linked to the baseline body weight. So if you have someone who is very obese, he will lose more weight. If you have someone who has a normal body weight to begin with, she will not lose too much of weight. So we can choose the injectable GLP-1 RA, oral GLP-1 RA or oral SGLT2 inhibitors to break the KGA1C paradox. One more question, and this is difficult. This comes from Haryana. All difficult questions come from Haryana. This is, sir, out of these four targets, which is the most important? Uh, Glucose, body weight, cholesterol, and blood pressure. The answer to this, sir, is all are equally important. I am reminded of the chariot that was used by Lord Krishna in the Mahabharata. Uh, Four horses. The English word for a chariot that is run by four horses is a quadriga, Quadriga. Now, all four wheels of a car or all four horses of a chariot are equally important if that vehicle or chariot is to run fast. Similarly, in diabetes care, all four targets are equally important: glucose, weight, blood pressure, and cholesterol. The problem is, and thank you, sir, for raising this question. The problem is that we seem to spend all our time focusing on glucose, which is relatively difficult to manage. It is much easier to manage cholesterol and blood pressure, but we don't spend so much time or so much importance while we are counseling our patients. So I think that is one thing we can do. We can tell our patients when they come to the OPD, these are our four targets, and finally our aim is good quality of life, happiness. We call it glycemic happiness, and we'll try to get all your numbers under control. So then, when the blood pressure comes down or when the cholesterol comes down, we should celebrate that. I actually do that in my OPD. When the LDL comes down or if BP is okay, we kind of cheer up and we say three cheers. Let's celebrate this. So thank you, sir, for raising the question. And the answer is all four are important. Another question that has come is polypharmacy. How do you handle so many drugs? I myself don't remember how many drugs I am writing. How can the patient remember to take them at the right time? Sir, this is where FDCs come in and they help us. So we are really grateful to Indian Pharma for having created Indian FDCs, fixed dose combinations. We are able to get these drugs at much economical rates as compared to our colleagues across the world. And actually, when you talk with endocrinologists or physicians from other countries, they are envious of us. So thank you to Indian Pharma for creating these. If you can use an FDC of triple oral therapy, the number of tablets comes down, the pill burden comes down. It becomes much easier for the patient to take the therapy at the right time in an appropriate manner. One last question. This has come for me, Dr. Banshi. The question is, what is the biggest mistake you have made in life? So I hope it is a professional mistake that's being asked. This is not related to diabetes care, but I go back to my MD days. Uh, I did my MD at PGIMS Rohtak, and in the OPD, there would be many ladies who would come in with so-called functional complaints, generalized aches and pains. At that time, alprazolam was a new drug, a very hip hop happening kind of a drug. So we would write that for all our patients who came in with aches and pains. It's only later that I realized that they had osteomalacia, vitamin D deficiency. If I could make one change to whatever I have prescribed in the past, I would like to go back and delete alprazolam from those prescriptions and change to calcium and high dose vitamin D. Why I say this is because at least now we should not make the mistake. If you have a patient who has come and made any complaint in your OPD, the complaint can be aches and pains. Do not rush to label it as functional. If patient says I have gas in my abdomen and it is rising to my head, this is a common symptom in Hindi. Gas बनती है और दिमाग को चढ़ती है. Do not label it as functional. There is actually a gut brain axis which is mediated by our microbiota. So maybe that patient's microbiota are actually speaking to the brain. There are bad bacteria or unhealthy bacteria in the gut and they are not producing enough serotonin. So that is why the patient has this complaint. So first of all, acknowledge the patient, appreciate the symptom. So you can say, thank you for having described your symptom in such vivid terms. This will help me give you the right medication. This is all you have to say. Instead of saying this is bakwas and there is nothing like that, you are imagining this symptom. Don't say that to the patient. So acknowledge and appreciate and then address it. And then you prescribe whatever you wish to prescribe, but do not rush to label a patient as being functional or having a psychogenic symptom without having done proper investigation or at least having taken a proper history. This is a message that I would like to share with you, and I am very sure Dr. Banshi Sabu will agree with me. This is the least that we can do in our OPD. Being human, being humane, and listening to our patient happily. Thank you so
Thank
much.
you, Sanjay. Thank you for inviting me and giving me this platform. Thank you.